to all. So very difficult to teach such an highly educated group doing so many procedures. So just to give a background of what has already been spoken, in the decision tree, it is most important to know that we are actually dealing with a true recurrence. There are certain conditions which need to be ruled out. Epidural fibrosis, hematoma, infection, iatrogenic instability with over-enthusiastic decompression of parts removal, and nerve root injuries, arachnoiditis, all have to be ruled out before we take a decision on surgery for a recurrence. Investigations like X-ray, MRI with contrast, CT scan, nerve conduction studies, particularly in a diabetic patient or where there is a associated neurological issue, blood test if you're considering any early infection, discitis, and always it is better to take a second opinion if there is any doubt in your mind regarding recurrence. X-rays help us in deciding on any sagittal range of motion abnormalities, more than 10-degree motion at the level, more than 4 mm translation at L4, L5, more than 5 mm translation at L5, S1 has been associated with post-op pain. Degenerative conditions, lateral listhesis, degenerative scoliosis can also be ruled out by a simple radiograph. CT scans can help us see if there is any associated ossification or calcification which was missed during the index surgery. Many a times we don't have a practice of doing CT scans for a simple disc prolapse. Then we do a CT, it shows up there is a calcification or ossification which can be the reason for persistent symptoms. CT also shows over-enthusiastic facet removal or pars lysis, iatrogenic pars lysis. As we all know, MRI helps in differentiating between a scar, epidural fibrosis, and disc prolapse with the established protocols. Also, it helps to rule out the non-indicated patient of arachnoiditis. If there is a clumping of the roots, that patient should not be touched. As summarized by the previous talker, prevention is the best cure. The best place to prevent recurrence is the first index surgery. An older male, more than 50 years, a manual laborer, diabetes mellitus, smoking are all non-modifiable factors. MRI-related factors like modic disc change to disc extrusion, intraoperative factors like slit annulotomy, keeping the annulotomy less than 6 mm, roughly the size of pen-filled tip, have all been known to reduce the chance of recurrence. Once there is a recurrence, what can we do? Conservative management with medications and injections can be tried for 6 to 12 weeks. A revisional microdiscectomy or a fusion can be offered. A diagnostic injection is reserved for atypical pains, conventional MRI findings. We need to ensure accurate needle placement, a good contrast spread, and if there is more than 80% pain relief lasting for less than 6 hours or so, we can be assured that it is probably related to the recurrent disc. Literature is all over, and there is recently good evidence for all procedures, endoscopic, microscopic, or fusion or otherwise. In a patient with inherent patient, fusion is better, but there are side effects of fusion like operative time, increased blood loss, longer hospital stay, higher cost associated with the fusion, but it is associated with a lesser dural injury, less nerve root injury, because we are taking a more lateral approach than the traditional microdiscectomy approach. The fusion is reserved for segmental instability where there is a facet cyst, deformity, lateral instability, patient with significant back pain, and iatrogenic lysis. When I worked with my mentor, I picked up 2 techniques which have been responsible for decreased recurrence in my practice. One of them is a standalone lateral recess decompression for a disc prolapse where there is not much of an extruded fragment. And also, once there is a recurrence, my go-to practice is what I've learned from my mentor, which is a MIS TLIF, going through a lateral approach and not disturbing the central canal. And I still now don't have any dural root or a nerve root injury in a recurrence. The literature supports fusion also, discectomy also. So the tree for the algorithm for management is if there is a contralateral disc and there is no significant back pain, it is straightforward to do a discectomy. If it is ipsilateral and there are significant factors which can affect instability and significant back pain, and if there is a second or third recurrence, we usually go for fusion. It is very important to consider the clinical factors, the patient preference, and surgeon expertise. When in doubt, it is always better to fuse, particularly with the working generation of Instagram which we have now. Thank you.
Thank you, Dr. Shashidhar.